This is Connie Clement, the Scientific Director of the National Collaborating Center of Determinants of Health. I'm very pleased to be doing a session with the Community Health Nurses Interest Group, and this is a health promotion seminar series. And I'm going to be talking to you today about fostering action to improve social determinants of health. Our objectives for this session are to increase your knowledge and understanding of social determinants of health and health equity, and increase awareness and understanding about how community and public health nurses can take action. And I want to start with a couple of slides to set a context by describing briefly the National Collaborating Centers, and specifically the National Collaborating Center for Determinants of Health, where I work. The National Collaborating Centers were set up after the water and SARS crises. At the same time as the Public Health Agency of Canada, there are 6 centers spread across Canada, each with a different focus: Aboriginal health, environmental health, infectious disease, healthy public policy, and methods and tools for evidence-informed practice, and ourselves, determinants of health. Our purpose is to improve the public health sector's use of scholarly and other kinds of evidence and knowledge. We're not primary researchers. We work in the newer specialty of knowledge translation, interpreting what's known from academic research, evaluation, and other kinds of assessments so that practitioners can improve their practices and have greater impact as a result of better ways of knowing. At the National Collaborating Center for Determinants of Health, we're here to support public health organizations and practitioners to use evidence and knowledge within the scope of their practice. And we try to respond to the needs of the sector by sharing, interpreting, and making accessible information and advice to inform how, within everyday public health work, it's possible to effectively improve and mitigate social determinants of health and advance health equity. Our end goal is improved population health in Canada and a smaller gap between the healthiest and least healthy. I'm going to briefly define a few terms, even though I'm guessing you're all are mostly familiar with them. Social determinants of health are risk conditions within people's living and working circumstances that influence the risk for or vulnerability to disease and injury. These are not individual risk factors, the kind of behavior and genetics that so many people pay attention to. There are a whole variety of lists, as this table shows you, taken from Toba Bryant and colleagues' work and published in Health Policy in 2011. But you'll see here this type of list that social determinants are distributed unevenly among a population, and they influence individual and group differences in health status. And according to the WHO's Commission on Social Determinants of Health, unequal distribution of health-damaging experiences is not in any sense a natural phenomenon. It's the result of a toxic combination of poor social policies, unfair economic arrangements, and bad politics. Sometimes people, even nurses and other community health professionals, have trouble describing the distinction between what might be called natural health variations and socially constructed differences in health status. And that's an important thing that we need to be able to communicate. So genetic and constitutional variations in congenital conditions vary, just like eye, hair, or skin color. So ill health increases, for instance, on average with age. Chance plays a role in the outcomes of infectious diseases. Behavior and chance hazards also influence personal health. And these variations are more often individual than by group. When such variations do exist by group, for instance, the distribution of Tay-Sachs disease or sickle cell anemia, I'd refer to these as inequalities in health. But social inequities in health, however, are distinguishable from those inequalities. They are associated with social determinants of health, and the social determinants themselves are systematic, by which I mean that they're not randomly distributed. They show consistent patterns. Most strikingly, those patterns vary across socioeconomic and income groups. The variations are produced by those social patterns, by policy, and by habit, social habit. And because they're socially produced, they're modifiable. And because as a society we don't modify those conditions, they become unfair. And I want to distinguish for a minute what I call equity in health versus equity in healthcare services. Equity in health strives towards the elimination of systemic differences in health status between socioeconomic and other groups. And the way I often describe this when I'm talking to people who don't work in our field is that the work that I do is to try and be sure that all infants will have a fair and equitable shot at being healthy as children and adults, regardless of the circumstances into which they're born. And often this concept is reinterpreted to mean improved access to healthcare services. And while an important foundational goal of Canada's medical system is universal services so that everyone has access to similar or same services, and they can retain that access as they move from province to province. But to be truly equitable healthcare services wouldn't mean exactly the same for everyone. They'd be matched to the level of need. And this might result in significant differences in access and use of services by differing socioeconomic groups favoring disadvantaged groups. But today, the way our healthcare system is set up, we're usually favoring privileged groups. I want to spend the rest of the presentation drilling down with you into the kind of actions that evidence suggests we should foster and that you can work on in your practices. And so I want to start by thanking and crediting Margaret Whitehead and Gloria Dahlgren. And I'm using 10 principles of policy action to foster health equity that they published in a report with the World Health Organization. So the first of these principles is to strive to level up, not down. That should seem really self-evident. No one would want to pull the top down by making the healthiest people less healthy. Yet opponents of equity approaches often warn about this danger. They warn that for the least healthy become healthier, we have to pull the top down, and we can certainly avoid that. The second principle is to be sure that we recognize that approaches are interdependent and they need to build on each other. And there are 3 pointers here. That first pointer of focusing on people in poverty is what we often refer to as targeting. You want to look at a priority group, a marginalized group, people who have vulnerabilities based on the circumstances in their life. And you're doing this, it's one approach, and it will help increase success to pull up the bottom and make sure that the gap doesn't widen. And that narrowing the health divide means that we want to be narrowing the gap between the healthiest and the least healthy so that we're reducing the disparities between the extremes. And that third approach is looking at inequities through the whole population, is that recognizing that health status changes with declining socioeconomic status across the health gradient, and so that you're trying to shift the gradient as you're trying to pull that bottom up. And the approaches are not just complementary, but they're interdependent. So step 1 in many ways is to target. Step 2 is often to improve the health of the least well at the fastest rate, and be sure that you're doing that while you're reducing the inequities among all groups. The third principle is to promote population health gains while you're reducing the inequities. I really think that this principle is a restatement of the first 2 put together. And it's made explicit because people argue that they're conflicting, that it's unfair to target or focus specifically on a particular priority group over other groups or the whole of the population, and yet to achieve both overall health goals and improvements for the least healthy, we need to do both of that. 4, be tackling the social determinants. And this really says to focus on the social and economic differences and the policies most often that influence opportunities, living standards, and also personal behaviors associated with different groups in the population. So if we look at working conditions, for instance, many Canadians will tend to think that occupational health and safety laws and unions level the bar, if you would, and so the playing field is fair. And yet there's really good evidence to show that insecure work, lack of benefits, exposure to hazards, rates of injuries, as well as poor rates for wages, really affect the working poor differently than they affect those who have stable work or more middle class or more upper class, et cetera. And so that you have policies that are disproportionately affecting different parts of the population. The third group is to monitor. Monitor the actions doing harm. Be sure we're assessing differential impacts, not just the averages. Disaggregate data to understand the results of policy changes. A good example is broad social impacts when people without benefits, short-term or long-term disability leave and income, are pushed into even worse economic situations when they have to pay for a medical service compared to others who can absorb an extra cost when they have a medical cost. So you need to monitor impacts that look at health impact assessment and be sure that those health impact assessments include equity measurement. As I review these lists, I always think each principle must be obvious, but you'd be surprised. For instance, when we look at 6, be sure to measure the extent of inequities and progress towards the goal. When we only measure improvement among the least poor, or we only measure improvement among participants in a specific short-term program intervention that you've done, we fail to understand if inequities are being reduced. So we need ways to measure relative as well as absolute changes. We need to assess shortfalls and cumulative differences between each successive social group. Principle 7, making efforts to give voice to the unheard and the effective. This really addresses the fact that those with power are given more opportunities, have greater influence, and tend to have resources to present articulate stories and arguments. So that we as health workers need to be making explicit efforts to provide means for genuine participation. And this includes understanding and circumventing barriers. Are the programs that you're engaged in paying for childcare, for transportation? Do they provide honoraria? Do they reach hearing so that everyone gets to speak, not just the most vocal? Do they support grassroots organizing so that groups can gather their thoughts, can design their own programs, can participate? And I think there's a real possibility for community and public health nurses to have a huge opportunity to play a role there, because community nurses play such an interface between community members, both disadvantaged and advantaged, and kind of systems that we work within. So you are often the conduit, the advocate, the one who's going to be able to argue for that possibility. Principle 8, and as you'll see in a minute, Principle 9, are both about recognizing that magnitude and causes of health inequities do differ, in this case between men and women, between individuals with different gender identification, and that we need to be analyzing that and be paying explicit attention to that. Principle 9 is similar. It's being sure that we're paying attention to ethnicity, to culture, to race. I think in Canada, if I was doing this list of principles, I would make geography a separate principle, because geography is, within Canada, the vastness and the regional differences are huge, and that the policy differences in health, how we affect health outcomes, become very different in the north from the south and in rural and remote regions. I often give an example when I used to work in Ontario, that the price of a bottle of scotch is the same in Moosonee or Moose Factory as it is in Toronto, whereas a bottle of milk in Moosonee costs 4 or more times as much as it does in Toronto. And it's our social policies that have allowed that to happen. When we think about ethnicity, culture, and race, they're whole a great mix of factors that interrelate in those different aspects. And some of the factors will will influence racialization and racism more, and those kind of influences. And I think we have to be very clear that in Canada, First Nations, Métis, and Inuit issues are a whole different set of factors because of the colonial and settler history that we have in Canada. Principle 10 from Dahlgren and Whitehead is really about they really argue strongly that if health equity aims don't match well with profit aims within health systems and health care. And I'll give an example from childcare, not so much the healthcare part, but one of the social issues. We have a lot of evidence that nonprofit childcare offers more recommended practices and has more positive impacts for children than for-profit daycare. And I think that, we have evidence across other aspects of healthcare. I want to take a couple of minutes. So those were the 10 principles that I wanted to talk about that we can integrate into our work and be really checking how we do our practice and are we carrying those forward. I want to take us to a couple of international processes and highlight what they prioritized in terms of action and what we need to put front and center. The Commission on the Social Determinants of Health of the World Health Organization was a multi-year international collaborative in which Canada was very involved. 2 Canadians served as commissioners. Canada sponsored 2 of the 10 or a dozen knowledge centers, one about early childhood and one about global health issues. And we contributed in a variety of different ways to the Commission. The Commission itself had 3 overarching recommendations for member states to improve daily living conditions, to tackle inequitable distribution of power, money, and resources, and measure and understand the problem and assess the impact of action. And the report, there's both a summary report as well as the full report, and there are reports from each of the knowledge centers, and I really encourage you to look at those documents. And in Canada, the Public Health Agency of Canada really plays a lead role at a country level to help us move forward on that commission. And we could do far better at acting on the commission recommendations than we are. Last October in 2011, member states of the World Health Organization came together in a world conference on determinants of health. And there were people from Canada there, from the Public Health Agency, from academia, from public health and regional health authorities, and from community organizations. And the Rio Declaration that came out of that conference set 5 challenges for us. And they build very well on earlier health promotion goals and aims, as well as on the Commission itself, and how that moves forward and how the Canadian government and the Public Health Agency choose to act on those is still not as clear as it would be great to see, but there's certainly action building. But these are things that you can look at to build into your work as well. And I want to close with promoting 2 sessions in particular next week, as well as the general conference at the National Conference of the Community Health Nurses of Canada. And that's happening during mid-May and 2012. And we're engaged as the NCC for Determinants of Health in 2 events there. We're doing a pre-conference full-day workshop on public health leadership to advance health equity. We'll have a first glimpse for participants from an appreciative inquiry that we've just completed. We'll talk a little bit about the form that some literature review that we're underway is taking. And in particular, we have a keynote panel of 3 nurse leaders who will be with us that day, as well as Claire Vector and Jane Underwood from our own organization and myself. And it's a very participatory day that you can take part in. And then during the main conference itself, we'll be doing a networking cafe on building community health capacity for intersectoral action to advance health equity. And we've just undertaken a rapid systematic review where we wanted to use that type of research or synthesis model to really say, what does the published literature say about effectiveness of intersectoral action? And because of the constraints of the literature and how the systematic review could match to that, we found little or moderate effect of intersectoral action in relation to social determinants of health equity. But we're going to share with you some of the limitations of that research and some of the ways that we're really, the learning that we're doing about intersectoral action and some of the other ways that we'll be bringing forward to bring you good evidence about what's working in intersectoral action. And then finally, if we think about nursing roles that you can build into your practice to contribute towards improved determinants, I think of nurses as the backbone of the public health workforce and so essential to community health centers and other community-based programs. And so in 2010, when we assessed the most important public health roles to address determinants, to a large extent we were defining what nurses can do in their public health and other community health work. And so the four roles that we really identified as being most critical to move forward determinants of health are a subset of the routinely defined public health functions. Functions like population health assessment, health surveillance, health promotion, disease and injury prevention, health protection, public health emergency preparedness and response. But the four that we really highlighted that will move forward determinants are to be engaging in community and multi-sectoral collaboration as a way to address the needs of populations through services and programs. This is what you most routinely do. But how do we always bring a lens to be not just improving population and individual health, but to be diminishing the gap between the least and the most healthy, to be sure that we're designing our programs in collaboration and that we're designing them to pull the bottom up, not just to be serving the healthy, the worried well, the middle class. Policy analysis and development, in particular leading and participating with other stakeholders in being sure that we're looking at policy, that we're using advocacy roles of public health, and that we're arguing for a big picture analysis that really integrates attention to inequities and that policies are focusing there. And then assessing and reporting on the health of populations, how we describe the existence and impact of health inequalities and inequities, and how we measure effective strategies to address those determinants of health. And I think you can do this at a program, at a neighborhood level. You can be arguing for that to happen at a regional level, and you can really understand the need to disaggregate data. You can also argue to include cases and nursing-based stories in addition to numeric data, because it's those stories that bring the numeric data to life. And then finally, to modify and reorient public health interventions. This is so much about being sure that we're including consideration of the unique needs and capacities of priority populations. One of our key initiatives right now is really looking at how could we be doing population health status reporting in ways that do better at illuminating inequities and driving towards policy. And we're working with a nationwide learning circle of public health and research experts to bring ideas to that, and we'll be releasing material very quickly from the first meeting of that learning circle so that you can see how that goes forward. And I think all of these, one of the other long-term projects we're looking at is leadership related to the piece that we're doing at the CHNC conference. And, how can we be supporting leaders at all levels, not just the former medical officers of health or the nurse directors, but those of you who are leaders from the front line. And finally, I just want to close by saying that Please look at our new website in French or in English. We put stuff up on Twitter every week. Our blog will become more active as we move that forward. And we're really working in 3 areas to bring kind of evidence and knowledge summaries, some of them written, some of those in videos, some of them a bit of a commentary from an expert to you. We're really looking at events both on the web and in person, and ways to promote useful resources and organizations that you want to know about. And then we're just building an online community of practice that we should launch by June. It's in test phase now, and then we'll be fostering exchange with all of the folks who participate in that community of practice and beyond as we meet you out in the field. Thank you so much for listening and viewing these slides, and I look forward to meeting you at meetings and across Canada.